This next test will be over upper extremity and shoulder girdle. So what we're going to talk about in this particular slideshow is fingers through humerus. We'll talk about some alternative positioning. We'll talk about the analysis and how to detect rotation, which way the rotation existed, if it did exist, and of course general positioning as well. So image receptor size, image receptor placement, image receptor orientation, and marker placement are similar to what we talked about in chest and abdomen. And again, my personal thought is, as long as it's marked properly and the marker is out of the anatomy, then the placement of the marker on the image receptor is really fairly irrelevant. So again, follow your departmental protocols and your physician's preferences for marker placement. But the image receptor, if you happen to be working somewhere where they have computed radiography, remember that the image receptor size can affect the sharpness of recorded detail that's inherent in that image receptor. So you always want to use the smallest image receptor that you can for the anatomy that you are imaging. Always collimate. I'm going to be pretty repetitive on collimation between now and graduation. Collimation has always been about improving the image, and that was generally by cleaning up scatter radiation, which it still does. But the benefit in screens and films was that eliminating that scatter radiation improved contrast. And we know that contrast is really a function of the computer algorithm now, and collimation might have some play in, or some part in, improving contrast, but primarily it doesn't do nearly as much as what it used to before the computer application. But it is a moral and ethical imperative to collimate, so you want to collimate as closely as possible without clipping anatomy. That's number one. Number two is that we've talked about the effects of collimation or lack of collimation on image size. If you don't collimate in closely, then in a lot of cases what you may have is an image size that's much smaller than what it should be, because your computer algorithm and your computer display is basing your display over the entire collimated field. So if you feed it collimated field on, let's say, a finger, and the collimated field is maybe 14 by 17, then it's going to display that entire collimated field, which is going to make the finger appear very, very small. And then once you magnify the finger up to make it readable, then you may lose some resolution. So there's some actual sharpness of recorded detail, not really recorded detail, but sharpness of display that comes into play with collimation. Also, though, on some of your CR systems, you've got to have a collimated field that the computer algorithm can recognize in order to not have a histogram analysis error. So very important to have your collimation proper in a CR setting, and it's very important to make sure that the collimation is as small as possible, tightly collimated as possible, to avoid having those miniature images as well. So your radiation protection is primarily your collimation, but it is good patient care to go ahead and cover the patient when it won't interfere with the exam. If you're using the table as a tabletop, and you're shooting with the image receptor on top of the table with the patient in a chair right there at the table, keep in mind that the scatter radiation that's going through the patient, through the image receptor, and through that radiolucent tabletop is going straight towards their gonads. So even if the primary radiation protection is your collimation, and you know you're not creating a lot of scatter radiation, just keep that in mind. It's a good idea to go ahead and put an apron on the patient. So our fingers, we usually shoot PA and lateral. We may include obliques. We'll want to make sure that we get any artifacts that we can take off of the patient. That would be splints and bandages, but keep in mind that the patient may have an arterial bleed. So if you take bandages off of the patient, you're probably going to, I won't say pick a scab off of the patient, but it may cause the bleeding to resume, and arterial bleeds will squirt and they will get you. Keep in mind splints on fingers. Generally splints aren't all that big of a deal, but when we get up into longer bones like forearms, and we get into lower extremities, legs and things like that, it's very important to be very careful with splints. It's a good idea for you not to remove splints. So anytime the patient has any kind of a splint, just the main thing that you want to pay attention to is what are the most radiolucent portions of the splint, and try not to shoot directly through that. If you do have to shoot through that radiolucent portion of the splint, then make sure that you understand your technique compensation. Keep in mind too that splints are not, they're not casts, so they don't go all the way around the anatomy. So sometimes where you have to penetrate the splint on an AP, you might not have to on a lateral. So make sure that you understand where the splint's going, what projections you may have to penetrate the splint, and which projections you don't. Collimation we already talked about. The central ray location for individual fingers is going to be to the proximal interphalangeal joint, so that first knuckle. Make sure that you open up your collimation to the tip of the finger, and make sure that you include the distal portion of the metacarpal. As far as comparison views go, some of your hospitals will ask for comparison views on opposite hands of the same finger, and some of your doctors specifically may ask for just comparison views between adjacent digits. So let's say the patient is a young patient and they've still got open epiphyseal plates. The doctor may ask for, and maybe they did some damage to their middle finger. Then the doctor may ask for comparisons just to open up your collimation to include the index finger and the ring finger, so adjacent fingers, to just compare the growth plates. So know your protocols there as well. So what we're going to look for in individual fingers is applicable anatomy and making sure that the anatomy is represented. So we've got from the tip of the soft tissue, and you want to include the soft tissue with the collimated field just past soft tissue. Center of the field should be right around the open proximal interphalangeal joint. We got distal portion of the metacarpal. We got soft tissue all the way around, and that's good. We want to make sure that the interphalangeal joints and the metacarpal phalangeal joint is open, and we do that by flattening the fingers out where the patient can flatten their fingers out. Sometimes you'll have a patient who has rheumatoid arthritis and they can't straighten their fingers out, or if they've got some sort of pathology or some sort of injury where they can't physically move their fingers. If they've had significant nerve damage, or nerve damage doesn't really have to be all that significant, they may have limited range of motion in the individual fingers. Advanced arthritis, they may have some fusion of individual digits. The individual phalanx So they may have a fusion at an interphalangeal joint. They may not be able to straighten it out. So we're not really talking about those patients, but if the patient can straighten their finger out, then you want them to get their finger straightened out. If you don't, then this is what you wind up with. And realistically, it almost looks like this patient's got some sort of pathology going there or injury that caused this. The other finger's pretty straightened out. This one is clearly not, but what you don't see is through the interphalangeal joints. So whenever you have the fingers bent, that's what you're going to be seeing. And the reason it looks like that is because the central ray is going to project the distal portion of the proximal phalanx over the proximal portion of the next phalanx distal to it. So we've got this situation going on so that instead of having a nice open interphalangeal joint space, you've got projection of the bone into the joint space. You just can't see through it.